Yusri, Taha. I'm a consultant in infectious disease and clinical virology, and we are going to be giving the second part of the talk that we started last month on antivirals, non-HIV antivirals. As you may remember that in the first half of the talk, we described the landscape of antivirals, highlighted the groups and classes of antivirals, and discussed the mechanisms of actions. And we selected the herpes group just as an illustration case for the principles that we discussed. And we deliberately omitted large viral groups like viral hepatitis and Hep B and Hep C, and respiratory viruses like RSV and influenza. But today we will just go quickly over the rest of the herpes viruses to complete the set. And then hopefully we'll have time to speak about antivirus in emerging and re-emerging human viruses. So we start straight away with the human herpes virus type 1 and 2, also known as herpes simplex 1 and 2. And in the context of hematopoietic stem transplantation, and the headlines that we normally look at when we're talking about antivirals is how frequent is the infection or the disease, what kind of presentation, and whom we give prophylaxis or preemptive therapy for, and for how long. And then, if there is any issues about drug resistance, we highlight that. So without prophylaxis, HSV1 and 2 may reactivate in 80% of transplant patients, and that normally happens in the first month post-transplant. And the presentation, as you know, is mainly mucocutaneous disease. We offer prophylaxis to all seropositive recipients, and we give them the prophylaxis for at the time until engraftment takes place, or if there is any mucositis, that episode resolves. Resistance to acyclovir, which is used in almost 100% of the case for prophylaxis, can occur. And if you've got a persistent rash in a person and you isolate the virus from them, the likelihood that you're going to find drug-associated mutations is up to 28%. And the mutations are in the thymidine kinase gene, and this normally confers resistance to acyclovir, or in the DNA polymerase, which confers resistance to both foscarnet and acyclovir. A very similar idea to the UL97 and UL54, respectively, in CMV. This is me, and the picture on the right is the NIHR research facility in the hospital that I work in Newcastle, in England. And just introduce you to this study that you may have come across or not, if it's running from your center, is recruiting. It's called PRIOR-1. It's a randomized multi-center comparative trial, and that is meant to assess the efficacy and safety of a new drug called pritelivir versus foscarnet for the treatment of acyclovir-resistant mucocutaneous herpes simplex in immunocompromised patients. Just to give you a few lines on this drug, it's a novel drug, and it retains activity against acyclovir and foscarnet-resistant herpes simplex, and it targets a novel target that we haven't normally targeted in approved drugs, the viral helicase primase complex. This is the complex that unwinds the double-stranded DNA to make it like single-stranded for the replication to start. And there is no cross resistance because of that with other agents, and it is actually more potent than acyclovir against herpes simplex. However, it has no activity against other herpes viruses, which is a shame, just like what we said last month about the letermovir with CMV. It has got, so we would like to have more broad spectrum antiviral that we could use with more than one agent, but this is the case here. The medication is well tolerated, although there was some safety concerns in the past about prolonged use in some animals. And it is available now through expanded access programs. So if you've got a patient who's drug-resistant HSV rash that is not resolving, you may be able to get hold of some pritelivir. Okay, so Next is the human herpes virus type 3, which is also known as varicella zoster virus, of course. And going through similar headlines, the frequency is actually high of reactivation of varicella, up to 65% if you don't offer your patient prophylaxis. The presentation is normal disseminated shingles, and we offer prophylaxis to all seropositive recipients, just like herpes simplex. But because the infection could be delayed up to 2 years, the duration of prophylaxis is normally up to a year at least. The rate of resistance and the mechanisms of resistance are very similar to HSV1 as we described earlier. Okay, we should just remember that the VZV is actually inherently less susceptible to acyclovir than herpes simplex. The next one is the human herpes virus type 4, which is also known as Epstein-Barr virus, of course, or EBV. And post-transplant, we're really worried about the post-transplant lymphoproliferative disorder, or PTLD. And this is very much associated with viremia, so very high viremia levels. But viremia is common, and not every viremia will mean that a person is going to develop PTLD. But the negative predictive value is good. So if your patient is not viremic or has got a viral load that is less than 1,000 copies per mil or international units per mil, then the likelihood of PTLD is almost zero. What do we do to prevent PTLD? Do we give prophylaxis? Do we give preemptive therapy? Well, the agent that we have and we've been using for some time now is rituximab. Unfortunately, it's a toxic drug itself, and the small studies done for prophylaxis actually failed to reduce the rates of PTLD. Definitely not to an extent that would stave off the side effects from rituximab. As preemptive therapy, though, so meaning that you wait for the virus to reactivate and then you start rituximab to stop PTLD from happening. This also has not been demonstrated very well. And although some studies, prospective studies, show some trend towards less PTLD cases, but that happened at the expense of increased risk for bacterial infection and actually a trend towards higher mortality in people who received rituximab. So at the moment, neither prophylaxis nor preemptive therapy are recommended for PTLD. However, there are people like the European Society of Infection in Leukemia, recommended, but they don't tell you when to start preemptive therapy. When the patient is 10,000 copies per mil, 100,000 copies per mil, 1 million, is just being left open for people to choose. I personally don't get bothered before they reach 10,000, and then I monitor them, and according to some kind of risk assessment, I may start them on prophylactic rituximab, but not as a kind of routine. Unfortunately, there are no antiviral agents that are recommended or could be recommended for prophylaxis or for preemptive therapy in EBV. And this is one large unmet need as far as antivirals are concerned. Okay, next virus is the human herpes virus type 6, and it's also known as human herpes virus type 6 because it was discovered after the classification or the nomenclature system was devised in the 80s. And if we go through the same headlines, HV6 is quite ubiquitous. Most people, or almost 100% of people, will be seropositive by the time they're toddlers. And reactivation happens a lot, in up to 40% of transplant patients in the first 2 months post-transplant. But it's just a viremia. It's asymptomatic viremia, and normally it resolves spontaneously. And the main disease is really the post-transplant acute limbic encephalitis, or PAIL. That is what you fear, and that's what you have kind of think of if your patient develop CNS symptoms. However, prophylaxis and preemptive therapies are not recommended as far as HHV6 is concerned. And there is talk about CTLs having a role in management of HHV6 viremias as a preventative measure for PAIL. I would like, before I move to the next virus, which is 8, is to just take the opportunity to highlight a few issues with HHV6. First, HHV6B, if you could see there in the title that I've written 6B, this is the virus that is responsible for most reactivations and is indeed the most frequent cause of infectious encephalitis post-transplant. However, the pathogenic role of HHV6A is not very well established, so we don't know whether it causes any problem at all or not. Second is the use of letermovir for prophylaxis against CMV in transplant patients now. In the past, we used broad spectrum antivirals like ganciclovir and foscarnet, which could actually, inadvertently protect against HHV6, but letermovir doesn't. So we don't know what is going to happen in the next few years when letermovir use becomes completely dominant. There are some studies already showing no huge difference. Maybe viremia of HHV6 is happening earlier than it used to happen. It is higher in load than it used to happen, but we don't know the clinical correlations yet. The third thing I wanted to highlight also that beyond established encephalitis case, there is recent evidence that HHV6 is implicated in pneumonitis and less convincingly in hepatitis. And in this regard, I just wanted to bring to you to your attention a fresh report this year from Nature.com that implicated HHV6B in pneumonia in kind of a compelling fashion. So they looked at 116 transplant recipients who got pneumonia, and they analyzed their BAL fluid for HHV6B DNA and their mRNA transcripts just to look for activity of the virus and not latency. And they also, in parallel, they looked at the RNA-seq, so the cytokine and other signature of the host at the time. And what they found that the HHV6B DNA was detected in 37% of these BAL samples, and the mRNA was detected in half of these patients in whom the viral DNA was detected. In fact, the authors established a DNA cutoff that was predicting or predictable of mRNA detection. So if you find the DNA at a certain level, you know the mRNA is going to be also detected. And also they found that that specific cutoff was associated with overall mortality and also with respiratory failure related mortality, which is quite, a strong data. And to bolster their results, they actually found that participants with viral DNA in their BAL fluid exhibited distinct host gene expression signatures. So that is quite corroborative of the results. So overall, the data implicated HHV6B as a pulmonary pathogen after allogeneic hematopoietic stem cell transplantation. And this is relevant because even if you have got a respiratory multiplex in your center or a pneumonia panel in your center, possibly HHV6 is not going to be part of that panel. So if you're completely stuck, possibly then you have to test for HHV6 in the blood and in the BAL and see if that is something that causing the problem. So early days, but this is a preliminary, very good report. Last herpes virus is 8, which is the Kaposi sarcoma virus, and there's nothing much to say about this in this context because the disease in post-transplant is so rare. Maybe Kaposi, but that happens really rarely, and we do not recommend any serological screening or viral load monitoring or any role for antivirals that we know of. Maybe in endemic areas where HHV8 seroprevalence is high, people may decide to monitor patients who have got antibodies and just have more attention to that idea. So that is that part, and yeah, I don't know whether if we want to ask some questions here or just proceed for the second part of the talk.
Yeah, we can see if anybody has a question. If not, we can continue.
Yeah, because this is a kind of different. Okay, so we come to this part, which is antivirals in emergent and re-emergent.
Yusri, sorry, I was trying to unmute myself. Yusri, just a quick question.
Yes.
Yeah,
Sure.
here.
Go ahead.
So listen, what about this human herpes 6 CSF when it's isolated from the CSF? Can you just talk a little bit about it?
Khalid, I can't hear you very well. I don't know why.
Yeah, there's a lot of background noise. So when the human herpes 6 virus is isolated from the CSF, can you talk a little bit more about that?
Oh, yes. Yes. Yes, of course. I was going to say to you here, remind me to mention the clinical challenges of chromosomal integration, please. But I just skipped over that. Yes, you have to have the clinical suspicion of encephalitis first, and then you can then interpret the results of the virus in the CSF. There is a problem with what they call chromosomal integration. 1%, at least of Caucasians, at least, will have the HHV6 genome integrated in their germline, so they just born like that, and it is not necessarily something that would lead to replicating virus. However, if you test any samples in the body, whether CSF or blood or any cellular material, you will pick up that virus, and that is the biggest problem for interpreting, because now we've got the BioFire platforms, and HHV6 is just part of that panel, and there is a 1% chance that you will just find HHV6 in the CSF, and that is not normally pathogenic or anything. So, but in a transplant patient where there is an encephalitic feature, clinical features, then of course the positive predictive value becomes higher, but still you have to look at the load. If you find it in the blood at very high levels that are persistent for days and weeks unchanged, and also in the CSF all the time, then you'll have to take that with a pinch of salt, and maybe that is not a genuine HHV6 DNA, and thereby you cannot diagnose encephalitis. I hope
thank you
is
so much.
clear.
Yeah. Thank you so much. I know about this genomic integration. I just wanted to hear from you, your perspective.
Absolutely.
Thank you. Yeah.
Thanks. So now cases. I've got this chap who I looked after for more than 10 years. He's 78. He had a history of gastric marginal zone lymphoma, cured in 2011 with chemotherapy and radiotherapy. And unfortunately, he was left with chronic autoimmune neutropenia, for which he received GCSF for years. But in 2016, we diagnosed him with persistent hepatitis E virus infection, which is a chronic infection, genotype 3C, and genotype 3 and 4 and 5 are prevalent in industrialized countries in Europe, while genotype 3A and B are seen more in North America, especially in the States. So this chap had chronic hepatitis E and had a ALT of 300 to 400, and his liver scan, FibroScan, showed deteriorating, consistently deteriorating. Every time we do a scan, it's worse than the one before. He started with a liver stiffness of 6 kPa in 2016, and by 2020, his elasticity reached 16.7 kilopascal. So he had advanced liver fibrosis as a result of persistent hepatitis E, which is not something that we normally think of as a chronic infection. We always tell students that this is a self-limiting viral infection, but it is not in people like himself and his background. So we wanted to treat him really, and we treated him according to the European guidelines of hepatitis E management, and we gave him ribavirin for 3 months, and 400 milligram twice daily, and he responded well, and his viral load was negative at week 8 and week 12 of therapy. And also he cleared the virus from his stools because he had positive stools for hepatitis E. But unfortunately, he relapsed 3 months after treatment, and we had to give him another course of ribavirin, this time prolonged for 6 months. And as you could see from the viral load here in these circles, he did not really respond at all. And according to the guidelines, we gave him, being desperate for him to get better, ribavirin with pegylated interferon, just like the way we treated hepatitis C in the past. And that was supposed to be 12 months, but we gave it for 9 months, and we stopped because of side effects of ribavirin and interferon, and because he did not respond at all. Not only that, he accumulated more, gradually a lot of ribavirin drug-resistant associated mutations that I'm not going to take you through, but you could see from the bars that they were not there. And every time we give him ribavirin, more mutations had accumulated. So by 9 months, we thought that that's it. So we're not going to give him this anymore, and we needed to give him something else. So we gave him convalescent plasma, from 2 patients who recovered from hepatitis E, who got good titers of neutralizing antibodies that we checked in the lab. And Michael Ancon is one of our registrars in 2019. He's a consultant now in Sheffield, who did this report with us. And unfortunately, the results were equally disappointing. In the top line here, you can see that's the thin line is the viral load. The viral load just didn't budge, didn't change at all. The hepatitis E antigen level dropped while he had received these 3 doses of convalescent plasma. But within hours of the last or the 3rd dose of convalescent plasma, his viral antigen level just went back to where it was before treatment, and there was no difference in the antibody level either. Very disappointing, and very sad for him, because he went through a lot, including admission for this type of treatment. Based on some in vitro evidence that hepatitis E can be inhibited with sofosbuvir, the antiviral that we have been using for hepatitis C, the NS5B inhibitor, because they're double-stranded RNA, single-stranded RNA viruses, their polymerase gene product looks alike, and people kind of showed in vitro sofosbuvir can actually work on hepatitis E. So we got approval from the ethics committee in the hospital and from the patient. He consented, and we started him on Harvoni, which is sofosbuvir plus lenacapavir, because we didn't have sofosbuvir alone. And it was amazing. Within a month, his viral load dropped to almost nothing, and it stayed negative for 3 months post-treatment with Harvoni. And this is what I really wanted to see, broader spectrum antivirus that could work on more than one virus. Unfortunately, just over 3 months post-treatment, he had a rebound of viral RNA. His stool remained negative and his LFTs remained negative. So we treated him again with Harvoni and ribavirin, and this time he suppressed very well. And 6 months post-treatment, he was still negative. That's when I left Newcastle last year. So I don't know what has happened to him, but the consensus was that if he is to relapse again, we're not going to give him anything anymore. That's it. We're not going to give him more ribavirin at all. But hopefully he stayed negative. So that's the case I just wanted to share with you, and maybe it will inform of discussion later. The second case I wanted also to share with you is a 34-year-old lady. She is known granulomatous polyangiitis, Wegener's, and that disease involved her nose and throat. She presented with a fever, blistering rash on the hands and soles of the feet, and sore throat and painful ulcers on her tongue, as well as some damage to her nails called onychomedesis. So that's how she presented to her team, and she was found to be neutropenic at that time, and her immunoglobulins were on the borderline low. IgG was 7.6, IgM was 0.4, and her absolute CD4 count, no, CD19 count was 0.03. So although her rituximab was given the last dose a year beforehand, but she never recovered very well following that. And she was treated as neutropenic sepsis by her physician. She was given antibiotics, antifungals, GCSF. She improved. Her rash became better. So she was sent home. But she came back 2 months later with renewed lesions appearing in her mouth and her hands and her feet. And also the mucomedesis has progressed to the index finger, the thumbs of both hands, the middle finger of the other hand, and you could see here. So it's like a mucomedesis is just the nail is just separated from the matrix proximally, and then it just falls off. She was quite distressed, of course, about that, and when she came this time, they decided to consult the virologist. And do you know what the virologists do? The virologists take swabs. So we took skin swab and throat swabs and stool samples because we thought, hypogammaglobulinemia, hand, foot, and mouth. Yeah, this is probably an enterovirus. And indeed, it was an enterovirus. And it's a Coxsackie virus A10, which is very well known to cause foot, hand, mouth disease, and also herpes angina, and to a lesser extent, GI problems. The other usual suspects of skin rashes were negative. And we scratched our heads and we thought, okay, this must be treated with immunoglobulin because of her B cell deficiency. And we gave her 2 doses of human normal immunoglobulin, and it was like magic. Her rashes within a few days, or actually a week after the last dose, her blood as well as her feces were both negative for the enterovirus RNA, because we found the virus in her feces as well. Of course, she's an enterovirus. So it was really pleasing that she had at last because when we saw her, she mentioned that she had actually had recurrent rashes before, that she just didn't bother about. And every time she takes maybe a rituximab, there will be something. And once she repopulates her lymphocytes, her rash improves. But now it was persistent, and we were lucky that we presented her case in one of the Infection Federation meetings, and for a year after that, I used to get emails and phone calls asking about what did you do with that patient, because we've got a similar patient who was on rituximab, or a man who is on rituximab as well. So it's not completely uncommon. We know about encephalitis, but a recurrent disease like this with onychomedesis is not very well described in post-rituximab patients. So, third patient, I was in the lab, and the scientist brought me 2 samples. One is labeled amniotic fluid and was labeled cord blood. And the request on them says 32 weeks pregnant, hydrops fetalis, and request viral screen torch. I hate the request of torch, because what do they mean? What are they suspecting? So the lab personnel were asking me, what do you want us to analyze these samples for? And I was like, 32-year-old WG, vaginal granulomatosis, hydrops fetalis. Could it be another case of enterovirus following treatment for vaginers with rituximab? And but enteroviruses are not very well known to cause hydrops fetalis at all. When I was a trainee, we thought that doesn't happen, and if it causes any harm, it's probably caused miscarriage through fever rather than a congenital infection. But my heart dropped when I looked at the field of the name. It was actually not a case 3, it was case 2 itself. That was the same lady coming with hydrops fetalis and within a day, actually, she had intrauterine fetal death. The child died, the baby or the fetus died, and the amniotic fluid was positive for enterovirus, Coxsackie virus A, and the heart of the fetus showed signs of myocarditis and fibrosis, but we couldn't find the viral RNA in the heart itself. So that was quite something for us. And the lack of antivirals for enterovirus were highlighted so much in every junction of this case. I can listen to your opinions later when we present the last case. And this is the last case is a healthcare worker. I'm giving it patient number 3 because there are 2 patients before her. This happened in 2018, and this nurse was the first healthcare worker in the UK to ever contract Mpox. She looked after a patient with Mpox who returned from Nigeria in the west of the country, Blackpool, and I think she was just, cleaning his bed and shaking the sheets, and she breathed in the viral particles, and she developed Mpox. So she was sent to our high consequence ID unit, which is a high isolation unit at that time in 2018, like any Ebola case. And the lady stayed with us for 40 days. And you can see here from the shaded area that we discharged her on day 39 there. And we were hoping to send her home when she is not infectious to anyone, but we don't know what constitutes infectiousness. The colors here you see in the red is the viral load in the plasma, and the yellow is in the urine, and the green is the viral DNA in the throat swabs. We gave her 2 doses of brimsterdofovir, and you could see here after the first arrow here, and after the second, the viral load in the 3 compartments fell down. The urine disappeared completely. The throat swab also became negative day 15, which is the second day after the second dose, and the viral load in the blood also became negative. But she rebounded like 10 days later, and her throat remained positive for the virus until we discharged her. Really reluctantly, but we couldn't keep her. She was absolutely well, and she needed to go home. But she was followed in the community, and on day 45, the throat swab became negative for Mpox DNA. So that this case just tell you about the viral dynamics in a patient who has been admitted and had brimsterdofovir. Brimsterdofovir, we couldn't give her a 3rd dose despite the levels in the blood and in the throat and everything, because she developed significant hepatitis with the first 2 doses. And this is something that I wanted to highlight for the rest of the talk. Okay, now Mohammed and Neil will know this very well. This is the RBI, the hospital that we trained in, Mohammed and Neil and I, and here in the top floor there, the 3rd window from the left is my office now. And in 2018, we admitted that lady that I just told you about. And we were kind of the flavor of the day for the national papers and the TV, because she was one of patient in a cluster of Mpox cases. And as you can see in the Guardian, however, we kind of almost forgot about Mpox. Because just over a year later, we were busy doing something, like more substantive as far as outbreaks are concerned. We admitted a Chinese woman who came to the UK 48 hours earlier to visit her son, who was a university student. She had a cough and a low-grade fever, so she was isolated in a local hospital in Yorkshire, and had a respiratory sample transported urgently to London, and her sample, as you may have guessed, tested positive for the new corona virus that was reported for the first time in Wuhan province in China a few weeks before that. Within a few minutes of reading the results in the National Lab in London, the lady was on the back of a high biosecurity ambulance. and she was sent to us in Ward 19 in Newcastle for admission. And that was the first ever case of COVID-19 admitted to arrived in our shores in the UK, and the rest was history. So we almost forgotten about Mpox. We shelved the trial for Pritlevia that I told you about earlier. And as we were just getting to, starting to settle in a near normal life post-pandemic, lighting struck again. And the RBI ID unit was back in the news, and we had the TV crews back to our car parks. This time we admitted the fourth patient with Mpox. That is May 2022. And that followed another 3 other patients who were diagnosed in the same week in London. And all patients were young men who had sex with men. And as you can imagine, that sent all the alarm bells ringing. And within 2 weeks of that incident, the WHO announced that there were more than 250 cases reported in more than 16 countries. And within 2 months, the number increased tenfold to 2,500 cases in maybe 37 countries. And by the time the WHO and the CDC and the UKHSA authorities stopped issuing running commentaries on numbers, more than 100,000 cases of Mpox were reported around the world. Only 7 locations of reporting were countries that were known to be endemic for Mpox beforehand. And of these 100,000, 32,000 were reported in the United States alone. 58 died. So that made the case fatality rate, 0.2%, something like this. So because I've received a lot of questions in the last few weeks by friends and family about Mpox, and people were mixing the 2018 to 2022 to the current and thinking this is the same thing. I'm just going to give you this slide, and I hope it's not too long. First, the Mpox was discovered in 1958. There were some outbreaks of pox-like disease in monkeys that are kept for research in Denmark. And that's why it's called monkeypox, because of that. But monkeys were infected maybe from another host, just like us, most likely rodents. And it was until 1970 when the first human case was reported, a child in the Democratic Republic of Congo. And since then, infection has been reported in many places, especially in Africa. It's become like epidemic in certain countries, or endemic, if you like, with some clusters happening every now and then after the cessation of smallpox vaccination, which probably protected the population there against Mpox in the past. Okay, but as I said before 2022, almost the majority of the cases that you would see of Mpox or reported in the WHO were coming from only 2 countries, the DRC and Nigeria. The United States had an outbreak in 2003, and that was called the prairie dog outbreak. Rodents imported from Africa, the prairie dogs got exposed, and then the patients get kind of infected by exposure to their pets. And the virus is divided into 2 genetic groups or clades. Clade 1, this normally or usually or in the past being called the Congo Basin clade, no longer, and clade 2, which also used to be called the West African clade, no longer. We changed the names from Congo Basin and West Africa to clade 1 and 2 respectively, and we changed the name from monkeypox to Mpox at the same time in 2022. And these 2 clades have got subclades like 1A and 1B, 2A and 2B. And the 2 clades in general, they are different, distinctly different from epidemiology and from clinical viewpoint. Clade 1 being more likely to be severe, higher viremias, higher household transmission rate and higher mortality, which is very important to the current situation. The clade 2, especially clade 2b that went to Europe in 2022, the one I just told you about, the mortality rate was very, very low, as I said, 0.2 or 0.1 in the United States and similar number in the UK. And as a result of that, that specific virus is no longer classified as a high consequence infectious disease anymore in the UK. However, this summer, there were more cases of mpox in countries that did not have clade 1 before. So historically, there are 5 countries where there's clade 1: Cameroon, Congo, Gabon, DRC, and Central African Republic. But from this summer of previous year, there were reports from countries beyond these countries, like Rwanda and Burundi and Uganda. And now we have got more than 20,000 cases in these countries and beyond, as far as Thailand and Scandinavia. And so far, 615 people died. So that is the situation now, a clade 1 outbreak with a subgroup that is being described. And unfortunately, the response to this plight in Africa was too slow, despite the WHO Director General declaring mpox outbreak as a public health concern or emergency of concern. And only this weekend, the first batch of vaccines are going to be arriving. I don't know whether they have arrived or not of the vaccine. And also this what pushed people like Gordon Brown, the former Prime Minister in the UK, to write in this weekend papers about the need to stand together. And he was pointing some steps to head off the disaster of mpox or stop mpox from spreading around the world again. So this is what is happening. The WHO also urging biotechnology companies to submit proposals for evaluation of diagnostics, because there are no diagnostics in Africa for this. And this is so important, as you all know, for the control of the outbreak. So we need to treat this, obviously, because people die, and they normally die from extensive dermal disruption that could lead to septic syndromes or severe inflammatory response syndromes or encephalitis, bronchopneumonia leading to respiratory failure, and some patients will present with cervical lymphadenopathy with or without associated airway or swallowing compromise. So we have to kind of find the patients who are likely to die of this or at risk of developing complication and target them for treatment. And people like immunocompromised patients, pregnant patients, neonates, and so on, and people who got significant skin disease beforehand. So I'm just going to give you an outline of the 3 medications that are possibly available for treatment of mpox. This is the life cycle of the virus, and you could see here the virus attaching to or binding to the receptor and then fusing the membrane before emptying its load of viral DNA and enzymes in the cytoplasm, where the viral DNA replication takes place and transcription and then translation of the mRNA of the virus into viral proteins, which can be kind of assembled together into an intracellular mature virus. And then the virus butts out of the cell and get released as extracellular envelope virus. And the extracellular envelope virus, or EV, is important for infecting other cells through the viremia. And the medication that I'm interested in very much is the tecovirimat here. And the tecovirimat inhibits a protein called P37. This is the protein that is responsible for forming the extracellular enveloped virus. Without it, the virus will stay trapped in the cell without leaving it at all. The P37 is a product of a gene that is conserved in all orthopox viruses. So it's got a name in cowpox, another name in vaccinia, and the third name in mpox, but they all kind of code for the P37 that is responsible for the extracellular virus formation. There's a point mutation in the position 277 in the virus that may confer resistance to tecovirimat, but mutations within the P37 may or may not confer resistance to tecovirimat. But if you've got a virus that is resistant to cidofovir, it's not going to be cross-resistant to tecovirimat. And we will come back to that later. The other two agents are cidofovir and brincidofovir. Okay, so cidofovir, of course, as you know, is approved for CMV for decades. It's a prodrug, so it needs phosphorylation twice to make cidofovir diphosphate, and it inhibits the DNA synthesis and also the DNA polymerase function. And resistance to cidofovir is very well described, stepwise fashion, but at expense of extreme cost to fitness. So a resistant virus is quite weak virus. The brincidofovir, on the other hand, is works exactly like cidofovir. It is a lipid conjugated cidofovir analog. It's approved in 2021 for treatment of smallpox, and is readily uptaken by cells, get hydrolyzed by lipases to cidofovir, and then get phosphorylated the same way. But the concentration of brincidofovir inside the cell is much, much, much higher than cidofovir. And I will show you this in the next slide here. So if you look with me, this is a comparison between tecovirimat, brincidofovir, and cidofovir, because you may be asked the question as which one do you want to start, or on which ground, if you have got access to the three agents. So brincidofovir and cidofovir both are broad-spectrum antivirals, so they are effective against many double-stranded DNA viruses, including, of course, herpes and adenoviruses, and the orthopox viruses, of course. But the tecovirimat is very specific for orthopox viruses, so it's got no effectiveness against other double-stranded DNA viruses. But you could see here at the EC50, the difference between the EC50 of tecovirimat and brincidofovir and cidofovir. So you could see that brincidofovir and tecovirimat are likely to be much better against orthopox viruses. This is, by the way, happening also, the difference also in other groups of double-stranded DNA viruses. What else that I wanted to highlight in this table is the per orum dosing. Cidofovir is given only IV, while brincidofovir is given only orally. Tecovirimat can be given orally or IV. So that's enough for that. And I'm not going to take you through the animal model data, but I just wanted to highlight the toxicities. So the renal toxicity is very well known for cidofovir, quite prohibitive, although we can manage it with prehydration and probenecid. Brincidofovir, the main side effects are GI and liver toxicity, as I illustrated in the case I presented, and ST246, which is the other name for tecovirimat, is pretty well tolerated and safe, and we gave it to quite a few patients in the big outbreak in 2022 and 2023. And actually, you can avoid, the small side effects that are there with, GI by slow infusion from phase 2 and phase 1 trial. So this one ticks the box ahead of the other two medications. This is me receiving my second dose of mpox vaccination. Khalid have seen my old, I shared with him my COVID-19 Pfizer vaccine in December 2020, I think, and it was a different time, wasn't it? So this is the vaccine that was offered to people who are working in direct contact with possible cases of monkeypox or mpox, and also people at risk like MSM and others in sexual health clinics in the UK. So in conclusion, cidofovir, brincidofovir, and tecovirimat all demonstrate activity against mpox. And tecovirimat, principally have better tolerability profile, but larger human studies are required to identify who's to give the treatment to, when to give it, and for how long to give treatment. We're giving treatment for 14 days with tecovirimat now, based on animal studies, not on any human studies at all. And if you're pressing in the US, I urge you to sign up to to the STORM trial, the NIH STORM trial, which is a trial for TOPEX or TPOX. TPOX is a commercial name for tecovirimat, and you can recruit your patient or include your patient in this trial. And if they are not eligible for the trial, and you can also get the medication, the TPOX, from CDC through the expanded access of investigational new drug. There's very clear criteria. If your patient is severely immunocompromised or have got active lesions, pregnant, lactating child, or protracted or life-threatening manifestation. These are all kind of eligibility criteria for giving your patient TPOX. And you can do that by just registering online for the TPOX registry, and they will send you an email to verify your center and yourself, and then another email to have access to the forms for the study. So I really encourage you to do that if you haven't done that, because you don't know when your next mpox case is going to arrive. Okay, so this is the last bit of the talk. Essentially, we need effective drugs for many viruses, especially emerging viruses of potential to cause pandemics, such as coronas and orthopox viruses. And the question was always, what is the quickest way to find these drugs, these wonderful drugs that we don't have? One approach is obviously to hope that drugs that have worked against a different virus, sofosbuvir worked against hepatitis C, can work against Hep E, or remdesivir worked against Ebola, it's going to work against COVID, something like this, some luck. Or alternatively, you can be rational and specifically target proteins of the virus in question so as to interrupt the life cycle of that virus. I strongly recommend looking at the theory here. It's expressed very well in this wonderful article that was published in the New England Journal very early during the COVID-19 pandemics, when people were scratching their head about how we're going to find and how we're going to develop antivirus for the new virus. So this is how the article went. So although the COVID-19 causing agent, the SARS-CoV-2 virus, proteins are, all of them are potentially useful or druggable targets. However, there are some proteins that were always likely to be more easy to find a drug against. They call them druggable. Among these are the spike protein here, and the two proteases and the polymerase. And as you know, we have targeted similar genes in other viruses, and it worked well. So the idea was that finding drugs that can bind to these viral proteins best and stop them from working would be the logical way forward, and should be the priority for research laboratory at that time. And actually, in reality, this structure-based kind of drug discovery has been important in finding antivirals for some time. However, in the past, the process was relatively inefficient, calculations were inaccurate, computers were kind of not as powerful as they are now, and only about 100 compounds can be docked to their target at a time. But since the 1990s, when a drug like nelfenavir was being developed using these rational methods, the power of supercomputers have increased by a factor of 1,000,000. So that now rigid docking of over 1 billion compound can be completed in a few days. And normally we dock kind of repurposing libraries, because if you find a target there that is a rapidly deployable compound, that would be fantastic. So if we have done that, and I guess this is what remdesivir was found. So they just doctored remdesivir against the RNA-dependent RNA polymerase of the newly discovered virus from Wuhan, because it was there already, remdesivir against Ebola, and they found it fit. So they straight away sent it to the clinical trials, and we started the trials on the recovery immediately. Also, people can look at the larger libraries, which contain billions of compounds, and looking at these would be useful for quickly discovering new compounds that are yet to be tested in humans. So that's what has happened, or that was the theory. And you could see that was actually exactly what was achieved. And for the first time, the translational science sector successfully executed rapid drug discovery campaigns and developed novel antivirals while the pandemic was unfolding. And within 2 years, we had two orally given therapeutics with emergency use authorization, Paxlovid and Molnupiravir. And these were followed very quickly in 2023 by another 2 agents. That is in addition to remdesivir that was there already, and many others that are now currently in trials or in pipelines. So the rapid antiviral drug discovery efforts, now, if you read in journals and things, in the circles of academia and pharmaceutics or pharmaceutical industry, this rapid antiviral drug discovery is called the sprints, which is a fantastic name, isn't it? So that is what happened. And my final remarks really is that antiviral agents discovery and use is at last gathering momentum, but not with the speed that I would want to see, because there are more than 200 human infectious diseases that have got no antiviral treatments, emerging or non-emerging. And there are significant unmet needs. Effective drugs are needed for many viruses, especially emerging ones, as I said, and also safer drugs are needed for viruses, including those who got approved therapeutics already, and antiviral compounds with broader spectrum activity are welcome. I would like to see that more, and more potent antivirus that can counteract the highly variable nature of viral genomes are required. I don't want to develop an antiviral and take really efforts in trying it, only to lose it the next day because of the highly variable nature of the viral creatures. So that's really it, and I'm happy to discuss any issues that you or any question that you want to discuss in the that we mentioned in the last 15 minutes or so. Thank you for listening.
Thank you, Yusri. That was very nice talk, and I will start with a question.
Yes, please.
Thank you for discussing the baby, the fetus with the hydrocephalus with the enterovirus.
Yes.
We see neonatal infection very common in our practice, and sometimes it's could be a mild illness, but a lot of time could be very severe illness with devastating outcome with myocarditis, liver failure, and overwhelming sepsis. 2 questions. So the first question is, if there is any antivirals in the pipeline for enterovirus, I think our newness might benefit from that. And then the second thing is IVIG in severe enteroviral infection. From what I read, it's very controversial subject and not routinely recommended unless there is a life-threatening infection. What your opinion about that? Use it or not?
Yeah. Okay. Well, the first one, the antivirals. Of course, you mentioned the neonatal enterovirus, and that's true. They come with all sorts of things, and it's quite devastating disease in neonates. But in utero, it's not commonly reported, and this is really a recent phenomenon that is being reported. This case that I've mentioned to you, prior to it, that was in 2009. Prior to it, there was not a single case of eye drops caused by enterovirus, leading to intrauterine fetal death. So antivirals. Unfortunately, the Pocavir, the drug that was licensed in the 2010, or not licensed, was about to be licensed, has not been licensed, and we used to have it as expanded access treatment. We can no longer find it, so that is supposed to be in the pipeline. So hopefully we will have it at some stage. The drug that called Policonazole, which was also actually that one was FDA approved, but it was removed from the market because of unacceptable side effects in 2005. That was the other drug. There is actually also thought that the molnupiravir, the agent that we're using for COVID-19, the orally available treatment, may work for enteroviral infections. So there are few things that are in the pipeline, but none of them is near like a phase 3 trial now is going to be reporting. So really difficult situation with enteroviruses. The IVIG, I agree, is controversial, but I always thought the controversy is coming from the nature of the bug itself. If you've got enteroviral infection, this enteroviral infection in this patient I presented was a Coxsackie A10. There are hundreds of other serotypes that are not necessarily cross-protective. So the IVIG lot that you are using, or the human immunoglobulin lot or batch that you're using, may have absolutely no proportion, no content of the antibodies that are going to be effective against that specific serotype that your patient is suffering from. And that is where the problem is. And that's why most of these trials and prospective or retrospectives showed IVIG did not work. In my case, that patient, it worked very well. The rashes disappeared, the nails grew back, and she never had a problem. Unfortunately, she got pregnant possibly at the final tail of her viremia, just before she cleared it, and that's how she got the neonatal or fetal infection that very early in pregnancy. But she herself, she recovered fully or despite so I guess just if you are dealing with a patient with a foot, hand, and mouth, the likelihood that you're going to have maybe immunoglobulin antibodies in the immunoglobulin batch that you're using is going to be maybe abundant. If you're dealing with an Entro 71, it might not be abundant. So you have to think about that when you use it, and that's why, because it's a blood product, people do not give it lightly, and it's very expensive too. Unless there is life-threatening problem, or a problem like my patient where the rash is really troublesome and it's recurrent and making her lose her finger nails, and then yes, you wouldn't normally just give it lightly. Having said that, people with gamma globulin, people who are primary immunodeficiency, they used to have these diseases in the past, and they used to lose their nails in the past. But now, once that diagnosis in childhood, they're given immunoglobulin monthly or 3 monthly for the rest of their lives, and that protect them against enteroviral infection, which is the counter argument of does it work or doesn't work. It works if it's given in a rational way.
Thank you, Yusri. And there is a question from Hamad and then Khalid.
I think Khalid before me. You can go ahead, yeah.
It doesn't matter. So thank you, Yusri. This is like really useful. I truly enjoy your talks. Like it's very enlightening, and there's a lot of good information here. So I have a quick comment and also like a question. So do you know what are the efforts that are made now in global health efforts that are made now in Africa? Because Paul Farmer, he wrote in his book, he died now, but I mean, he wrote in his book like about the Ebola and how it's like when an outbreak happens in Africa, they don't dispense any vaccines or medications. They just like, mobilize resources to just contain the virus, not actually doing active intervention. And I know that you just mentioned that they're giving the vaccine. So are they actively vaccinating people there or no? Do they have these
No, yes,
drugs or no? So this is my
no,
first part.
no,
And
no. Unfortunately, yeah. Go ahead.
yeah, my second question is like just that like the onychomatosis, the nail changes. So that what made you suspect? This is very very interesting. So that what made you suspect the Coxsackie, and how did you guys swab? Like what did you guys swab exactly? Was that like the nail bed, or was there like vesicles, active lesions that you swabbed, or what is it? Thank you so much, Yusri. Again, this is very helpful.
Not at all. Okay. Well, the situation of mpox in Africa now, well, Khalid, is disheartening. Is really, really disheartening. I mean, after all this and after what happened in the past, and what we've seen, HIV in the past. I mean, people just kind of haven't learned the lessons. And the response I had seen for the clade 2A or B outbreak in 2022 in Europe, and definitely you've seen in the US, is absolutely huge compared to what is happening now in Africa. And I think with the arrival of the two first cases outside Africa in Thailand and in Scandinavia, maybe the rich guys can start to do their duty and their job in protecting others and protecting themselves in that, because this is not going to respect any borders. This is going to spread if it's not contained very well. So that is from the containment viewpoint, and which is for which diagnostics or vaccinations or antivirals, the three of them are very important to be deployed as quickly as possible and as optimally as possible in Africa. And I don't know whether I mentioned this in the talk or no. Last week, there were 1,000 cases of mpox in the Congo DRC on its own. 1,000. Do you know how many tests or test kits, just individual test kits, were delivered by the WHO to the whole world, global mpox kits? 30,000 from 2022 until this minute. 30,000 to the whole world, and of this, only a quarter went to the Africa region of the WHO. And so that means how many? 8,000. How could 8,000 tests cover something like this? If I tell you that in 1 week we had 1,000 cases, so it's really poor diagnostics. The vaccines are just going to be a small batch. There are what do you call it? Commitment by US, Germany, France, the WHO to provide. One of them providing 20,000, one presenting 15,000 doses, because they are stockpiling these vaccines anyway. So they are now giving it, but there has to be a scale up of making vaccines the same way we've done it for COVID-19. And maybe the best thing is to manufacture that in Africa or manufacture it in India or some place, just like what we've done on the AstraZeneca vaccine in the past. But so far, nothing is being done. And as I said, the first batch, which is probably going to do nothing, is going to be delivered this weekend. And I don't know whether it has arrived there or not. When it comes to medications, that is even more difficult. Tecovirimat and bronzodovir were licensed for smallpox, not specifically for mpox. Clinical trials are not being completed yet, and that's why the TPOX trial that I mentioned is very important, and we would like to have it finished. Then the medication can be licensed by the FDA, and we will know for how long to give it. So the medications are not going to be given. So it's still going to be mainly conservative, symptomatic treatment, which is going to be difficult, as you know, in Africa. If somebody develops one of these complications, they're probably going to die because of lack of ICUs and the difficulty in actually doing proper infection control with these severely sick patients. Those who are not sick, they would not need antivirus, and probably they will not need to be admitted anyway. So the infection control is not a big issue. And as we have learned before, and in that fantastic recording by Professor Taha, healthcare facilities are a big problem, a big area of propagation of the virus. And my case I presented here, that healthcare worker, was a testament to that. You asked about something else, Khalid. Did you ask about
Swapping. The swapping. Thank you, Yusri. The swap. Where did you guys swap the nail?
No, not really. We didn't swap the nail, but that patient, because she got the virus in the stools and in the throats, and of course in the lesions in the hands and feet. But I think, if I'm not mistaken, because I haven't read the case for a long time, I think others have done that, and others have found the virus in the nail bed.
All right. Thank you so much. Thank you. Very helpful. Thank you.
Thank you, Yusri, for the very informative talk. Yani it's very nice combining science with clinical cases, especially the pathophysiology. A couple of questions, actually. As you already sort of mentioned about herpes viruses, very interesting, 8 viruses, mainly sort of characterized by latency and reactivation. And the role of the T cells on controlling these viruses. My first question about the EBV, I'm always been fascinated about EBV. This is, HLH and, BTLD. As you mentioned, for example, herpes and VZV are more common than EBV, BTLD in hematopoietic stem cells. Do you think there is host factors, probably sort of leading to the control and the, proliferation of the EBVD? That's why it is less common as compared to the other herpes viruses. So EBV and BTLD in hematopoietic stem cell. The second question is, as you already showed in your patient with Wegener's and rituximab and then enterovirus, do you think in the future, as we use a lot of biological treatment to control, these, cell receptor, especially T cell CD20, that we're going to see more sort of variety of this exotic infection, as you already mentioned? Thank you.
Yeah, thank you very much, Hamid. Yeah, I mean, just like you, EBV is absolute nightmare. We don't know what to do with it. The PTLD risk factors, as you mentioned, is the lack or loss of T cell surveillance, that we just allow the virus to go into overdrive and drive the monoclonality or clonality of the B cells, leading to PTLD or frank lymphomas. And I think the difference between it and other herpes viruses is just to do with the nature of it. So the herpes 1, 2, and 3 are alpha herpes viruses, skin and neuronal tissues. The latency and the latency genes are less likely to trigger that kind of proliferation, while the gamma herpes viruses, which is number 4 and number 8, Kaposi sarcoma virus and primary fusion lymphomas, as well as, of course, the EBV here in Hodgkin's lymphomas or non-Hodgkin's lymphomas and Burkitt's lymphoma and the PTLD, is the nature of the virus itself that can take advantage of the down tooling of the T cell surveillance and just takes advantage of that. And I absolutely think that CTLs are the treatment here. I've got a slide or 2 on CTLs here. I just deleted because I thought, the talk is going to be too long. EBV, the most promising and working things against PTLD and against maybe prevention is CTLs. And now there are products that have been kind of made available by different groups in US and Europe. So that is the way forward. Biologic therapies as treatment for other things that could lead to severe viral infections, absolutely. But also, there are now more and more kind of design medications that could hopefully work on viruses and host receptors, and these are probably the best that could satisfy that kind of hope that I mentioned earlier, broad spectrum antivirus. So if you can block where the virus work in human cells, that could probably be broad spectrum rather than trying to chase an ever-moving target with the viruses. But yeah, biologics are a problem, but we see that not just with viruses, we see it now with bacteria, and we see it with other, and every day there is a new development, a new procedure in stem cell transplantation or in solid organ transplantation even, and that will have impact on what we do in infection.
Thank you.
Yusri, I think there is a question from Nidal in the chat.
Yeah.
She's
Okay.
asking, can you tell us about monkeypox vaccines? Does it protect for all clades as a smallpox?
Yes. Yeah. So the orthopox genus to which the mpox belong or belongs contain other members like smallpox, of course, cowpox, camelpox, Akmeta, the Borrelia pox, which used to be called Alaska pox virus. These are all orthopox viruses, and they are all cross-reactive and all cross-protective. So if you got infection with one of them, you're going to protect it against the other one. And that is the essence of the success of the smallpox vaccination in the past, because we did not give people smallpox vaccine. We gave them vaccinia virus vaccine, and that protected them against smallpox to the point of eradication. And we eradicated because smallpox doesn't have any reservoir in nature. That's why it was eradicated. So yes, so the vaccines that are available now are licensed smallpox vaccines, and they are derived from vaccinia virus, just like the old smallpox vaccines, and they work well. That has been proven through the trials, and there are 2 of them, and normally given in 2 doses that are 1 to 2 months apart. Yes, if you have them and you are a person who's dealing with rashes, like dermatologists, ID physicians, sexual health clinics, because the ongoing outbreak of the type 2B, clade B1, the one that happened in Europe and States and still going on. حتى هنا in Saudi Arabia, I've seen a case a few weeks ago. This one is mainly a sexually transmitted infection, or supposedly sexually transmitted infection, because it happens with very close exposure, and it happens in the circles of men who have sex with men. So these are the people whom should be really immunized. So the small clades, the subclades, are not important. So if you get a vaccine, hopefully the vaccine will protect against all clades, because these are the clades within mpox. But the true matter is that the cross protectivity is not just confined to mpox. It goes beyond that to all members of the genus of orthopox virus.
Okay, sounds good. So, Yusri, where do you see this among mpox outbreak going? I mean, do you think it's gonna go along for a while, or what do you think should happen? And we as healthcare workers, should we get vaccinated, or what do you think?
Which one do you mean? The one that
No, I
just
mean
happens
the
now?
mpox. No, I mean I don't know where is this happening. I had to give a lecture in a medical school 2 years ago about the monkeypox. And I did actually, and I anticipated it by now it'd be gone. But I mean, we're still seeing cases. And where is this going? And we should get vaccinated, or what do you think?
Yeah. So as I said, the one that is ongoing since 2022 is a specific lineage within type 2B. It's called B1, and it is not that infectious. to be honest. And we have done studies like the one I just showed you. In that case, we know the viremia is not that long compared to type 1, and the household infectivity is not that high. So you need that close, intimate exposure for a virus to be transmitted if the person who's affected having got so many lesions that are covering his or her body. And that's why it was happening in certain age groups and in men more than women, and in really, as I said, very close household contacts. So, and yeah, I mean, I don't know how many cases were reported by the CDC last month. I think they were like 15 or 20 last month. So that trickle, we're probably going to continue all the time for years. It's just going to be like this. And there's nothing that is going to stop it now suddenly or make it go away, except for a big vaccination campaign, which I cannot see being done. I think the vaccination is going to be done as ring fencing for outbreaks, like the one that's happening in the DRC. So if it's up to me now, I'll just immunize everyone in the DRC, everyone in Africa Wusta, like this, because there's no other way that you could do it, in a cheaper or if better effective way. In the US, in the UK, we managed to immunize high-risk groups, and the rest of the population were okay. They were fine. But the cases are not going to disappear, I think. This virus is out in the open, and it's not going to just, even if we don't see it for a year, it will still be there, and it will still be kept with somebody who's immunocompromised, a small lesion here or there, just like other viruses. And it will, and it's been there, Khalid, in Africa all these years. Yes, of course, they get boosters because they get exposed to the animals where the rodents are infected, or monkeys or whatever, or the prairie dogs in the US. Because most of these people, or almost all the people in the US in 2003, were infected from exposure to their own pets. So this is the problem with this. Smallpox was easier because it doesn't infect animals at all. These ones infect animals. So, there's no way to eradicate them. The best thing you could do is hide endemic areas, you immunize people, you bring that size of epidemic to the smallest level, and then people cannot take it and go to airports, and then it's out, and as we said, it's more infectious. So I'm really worried that there were cases in Thailand or cases in Sweden, I think, or Norway. Really, really worrying. I just hope that in these countries the infection control becomes really good, and the outbreak control done well, then it doesn't spread like the other one. The other one, I think what helped it was the nature of the population in which it emerged. So most of the men who have sex with men in London who had that, it was summer, there were a lot of parties, there were a lot of group sex, that kind of thing. So suddenly you got like 20 or 30 people infected in one night. And then they go to their own cities in Manchester or Newcastle or Birmingham, and there was something similar that happening. It was just like an explosion. And that's why it's not something that we should really, even now here, the cases I've seen in Saudi Arabia here was young men, although they're denying having sex with men and everything, but it just is very similar, if you know what I mean. It's very similar population, it's very similar look of same young men, and I haven't seen it in a woman here. I've seen it in just that type of men. So I think it's here to stay, and the vaccination is going to be very, very useful in limiting it to very, very high risk people only. Just like maybe HIV, not as bad as HIV, but is going to be similar to that.
Okay, thank you so much. I really feel like I can listen to you for like all day. So thank you. I'll stop here.
Thank you, Yusri, for the very nice talk again. And if no one has any questions, we'll conclude today's session. And we hope for everyone to volunteer for our next presentations.
Okay, well, thank you so much all for being here, and thank you for your support. And yeah, we hope to meet next month.
Thank you. Take care.